The information was put together by Andy Allison, Director of Medicaid, talking about the projected shortfalls in Medicaid and the goals of this initiative. And there's four that we chose not to do. One, to address that shortfall, we could look at reducing the payment for all providers, regardless of their quality of care or efficiency. We could continue to pass on costs to the consumer through higher premiums, deductibles, copays, or taxes. We could look at intensifying payer intervention and decisions through managed care or elimination of expensive services. Or we could just eliminate coverage for certain expensive services or eligibility. Instead, this initiative's aim is to transition to a payment system that rewards value and patient health outcomes by aligning financial incentives to incentivize quality care, efficient care, and that's the goal that we've chosen with this initiative. The principles are on page 6. We wanted it to be patient-centered, focused on the patient, clinically appropriate, practical in scope and implementation difficulty, and based on data that make design decisions based on facts and data. And to this point, we worked with a number of constituents, and as the slide on page 7 indicates, over 1,000 providers, patients, family members, and other stakeholders have been involved. We've held 29 or more public work group meetings, over 26 months of research, data analysts, interviews, and infrastructure development to launch this episode payment initiative. And then monthly we provide updates to many of the Arkansas provider associations, including the hospital and medical associations. The episode-based model is designed to reward coordinated, team-based, high-quality care for specific conditions or procedures. And I think the key there is the coordinated, team-based, where we coordinate across all the providers that are involved in an episode or procedure. The basis of the episodes as designed to this point is that there's what we call a principal accountable provider or a quarterback provider. It's designated to be accountable for all pre-specified services across the episode, and we call them a PAP. That provider is selected based on a number of criteria that we'll go over later, but hopefully is the provider best positioned to influence quality and cost of care. And then we want there to be incentives. We want there to be positive incentives for providers that perform at a high level for both cost and quality across each episode. A little bit about how it works on slide 10. Patients receive and providers deliver care exactly as they do today. There's nothing that's changing in the way providers are paid on the front end for the care that they deliver. Claims are submitted the same way they are today. Payers are reimbursed the same way they are today. All the adjustments that are made in the episodes are done retrospectively, and that happens as indicated on page 11. We calculate the incentive payments based on outcomes after the close of a 12-month period. So all the episodes are over a 12-month period. That's not necessarily a calendar year, but is a 12-month period. Generally, we're looking at 3 to 4 months after the end of the close of that fiscal year to make the settlements. We review claims from the performance period for each principal accountable provider. We average those costs for each episode, and we compare those average costs to predetermined commendable and acceptable levels. Now, not every episode care is included in the final settlement. There are adjustments and exceptions that are made, and we'll cover those in a little bit. Based on the results, providers either share in the savings, in other words, receive additional payments if they are below what we call commendable levels and the quality targets are met. If the costs are above the acceptable level, there is a clawback payment. And if they're in between the acceptable and the commendable levels, then there is no change in the amount of payment that was made. And this is illustrated on slide 12 in the graph. You can see that they're acceptable. This is a chart of the average cost of the episodes across all the providers that are in the episode. Above the acceptable level is the outlier, and those are where the clawbacks occurred. Between acceptable and commendable, there's no change in the net amount of reimbursement that's done. And if you fall between the commendable line and the gain sharing limit, that is the extra payments, that is the savings sharing, that's where that occurs. Any episode that's below the gain sharing limit is considered to be questionable from a standpoint of quality and totalness of care, and that's why there's a gain sharing limit there. On slide 13 now, ensuring high quality care for every Arkansan is at the heart of this initiative. We know the quality has to be there and is a requirement to receive a performance initiative. There are two types. There is a quality measure that is required to be passed to be eligible for gain sharing. And then there are quality measures that at this point we are just tracking. As you can see from the two paths, there are two types. Core measures, basic standard of care, and then quality requirements set for these metrics that have to be met. And those quality requirements for the payment either are embedded in the claims information so we can tell and measure those from the claims themselves, or in some cases we require that they be entered into the provider portal that has been set up for the quality initiative. And then there are the ones that are used to track but are not linked to the payment. And on page 17 and on page 14 and 15 are examples of the type of reporting that each PAP receives. Currently, those reports for all payers can be found on the AHIN system. They come out quarterly. Depending on when the episode is initiated, usually there is what we call a preparatory period, which is kind of like a practice period where we use historical data to show how you would have done against the thresholds in place for that time. And that's what these reports are designed to indicate. And to this point, we launched 5 initial episodes in 2012. Those are listed on page 16.
Question was, when does the 12-month period begin? And it really depends on the episode. So very often what we have done is that when we finally go through this discussion period, we have a finalized version of the episode. It goes through appropriate public review. We then usually give everybody a report card, like in the handout, of their previous year's experience. So you can actually see where you are, what you've been doing, how you compare to your peers, what your quality metrics look like from last year. There would then be like a 3-month window where you could make some adjustments before the period would begin. So last year some of them began in October, then others began in January. So it really is where we stage and initiate the time. But usually it's about 3 months after the initial publication of a report card from the previous year's data.
Does the 12-month window, is that adjustable? Does it go to 18 months? Does it go to 3 years? Is it shorter? And is it adjusted going forward year over year?
For the most part, it is a 1-year window. When in the perinatal, what we did actually was a little bit, in the first year is a little bit difficult, but the trigger is the birth of the child for the obstetrician. So usually it would account for the care delivered or given before the birth of the child, and you become accountable for that birth if you've had the mom in your care for at least 8 weeks. So in some ways, there's a bit of a backwards look. For some of the surgeries, it could be 30 days before and 90 days afterwards. So for acute episodes, it's a year of those. For chronic disease, it's a whole other matter. But for the most part, it's a year of episodes that you do which are triggered by the event. That's risk adjusted. Plus, you'll be getting periodic report cards. So if it's a chronic year management, you'll get a rolling set of data usually to give you some sense of where you are. Another question here in Little Rock.
Yes, the collar, for lack of a better word, the acceptable threshold and the commendable threshold, are those set for each hospital individually, or is it a city or a statewide?
Statewide, it's one set for everybody. So basically, you are it's a normative process comparing you to all your peers. So if you're middle of the road, but basically, as David Greenwood said earlier, what we're not doing is slashing benefits for everybody or slashing reimbursement. And let's say, for example, say the top 15% most expensive would be potentially at risk. That means 75, 80, 85% of physicians are either revenue neutral or winners in the system.
And these targets are set prospective. We set them at the first of the year. This is an example of what would have happened if we set them retrospectively against past claims. But they're actually set prospectively, and they're set by contract for Blue Cross. And so you have the opportunity, if you're a high provider, during the year to bring that down. And so we would actually like to see the whole thing slide to the right, because even though we would pay out more in gain sharing, as long as it's sliding to the right, total cost of care is going down more than that. And so it's kind of a win-win for everyone.
That's right. The levels are not set after the year. They're set before the year starts. Was there, I think there's a question from the remote side for a second, and we'll get, does anybody on the remote side have a question?
Yes, I do. When we expect a new episode to start in 2013?
I didn't quite catch it. When do we expect what now?
The new episodes. The one we're talking now about.
Oh, the ones we're doing now. Okay. This would be a process where, it's probably wouldn't be till the fall. I mean, we're looking here at setting something up, getting it done this spring. There'd probably be a period of time for setting it forward in front for review. So my guess is you wouldn't see a report card on this until June, or maybe.
Yeah, on the neonatal episode, some of the other medical episodes, the timeline is more clearly set already. For the neonatal one, because as we'll get into, there are many sub-episodes within it, I think the payers are still soliciting input from the group, and very shortly we'll incorporate the impact and then come back with more of a proposal for the design and also timelines and so on. But it would not start before, the report cards would not go out before middle of the year or later in the year and so on.
Another question here on Little Rock.
So I assume that the objective is to slide the curve to the right, that I would assume that the premiums would likewise slide to the right, and that would be as public as this information from your organization. Is that correct?
Yeah, so if you're talking to Blue Cross.
That's right.
Yes, and with the MLRs and the changing environment, there is a limit to profitability at Blue Cross, so we would see these premiums go that way as well, we think.
You see the 30,000-foot diagram of the neonatal patient journey. Basically, the trigger is the birth of the child. There is prenatal care, but that is not directly part of this. And you can have a full-term birth or a premature birth. You can have a complicated infant or a not complicated infant. You will see that there would be either a fairly routine care, moved from labor and delivery to a floor with routine kind of assessments and preparation for being sent home. There will be potential for closer observation because of the gestational age or presentation, or there could be a need for very significant kind of interventions and longer framework of care. So sometimes you'll need, beyond just monitoring, IV lines, ventilator support, respiratory support, etc., occasionally even significant transfers because of the gestational age and risks of the child. So on the next slide, you can see that there is a variety of, if you will, areas where there are potentials for practice variation or for economic value, but particularly we call it practice variation, where depending on how things are managed, you can have different outcomes and different costs. So obviously, if we could reduce prematurity or complications of the pregnancy, that would help, but that's a different episode, really more for the perinatal as opposed to the neonatal episode. You want to make sure that the child is born in the appropriate setting, and I know there's a lot of activity going on right now about neonatal units, but in particular the need for complex children to be the moms to potentially be transferred, if possible, to a level 3 unit prior to the birth of a very complex child. The appropriate duration of care, appropriate intensity of services, appropriate timing and use of nutritional support, and obviously avoidance or management of complications in the neonatal period. The real question comes down to there's a great spectrum of presentations in this episode. So you have complicated term neonates, you have complicated premature neonates, you've got normal deliveries, you have children being born at fairly basic nurseries, level 1 units in fairly rural settings. You have children born at hospitals or transferred to hospitals with very complex high-tech technology to support the care.